Good afternoon, everyone. Welcome to this week's edition of the His Health webinar series. My name is Amora Amoyde. I'm the Associate Director here at NASDAQ working in Health Equity and Healthcare Access. I'm the Project Director on the His Health webinar series. Today's series will be focusing on sustainability and enhancing access and financial viability with a special focus on CBOs who are also functioning as aid service organizations. So we're really excited today to be joined by Xavier Robinson, who is a consultant on the His Health project with expertise in health systems integration and is now also the current Director of Practice Improvement at the National Council for Behavioral Health. In addition, we have TerMeer, who is the Executive Director of the Cascade AIDS Project in Portland, Oregon, and we want to welcome both of them to the webinar series today. Just a few housekeeping rules. Our phone lines are all muted until the dedicated question time. Please be sure not to put your call on hold. There will be time for a Q&A at the end, and we ask folks to use the chat feature down below to enter in your questions. You can send them written. Following the webinar immediately, we will have an evaluation link that will be sent out for participants to take, and we would really appreciate your feedback on this webinar. So before we start, I always like to give a little bit of background information about the His Health resource. So hishealth.org is an online platform that is dedicated to providing resources and training materials and information on great programs and CMEs and CMUs that have great promise for better engaging Black MSM into care. In terms of who we are, His Health is a united community of both healthcare providers and advocates, and we are all passionately committed to elevating the standard of care for Black gay men. We are very clear that in order to shift the epidemic, the responsibility needs to be a shared one amongst providers, Black MSM patient communities, as well as administrators who are operating at every level of our U.S. healthcare systems. We are also very clear about how stigma, discrimination, racism, and medical mistrust operate as tremendous barriers for good health among Black gay men, and we are addressing it clearly and sort of moving forth with being very clear on how that operates, and we want to do something about it. We are 1,000% committed to restoring trust, breaking down silos, and embedding improved communication between healthcare provider communities as well as Black MSM patients. In order to grow strong, we need to work together. And our vision isn't necessarily a world that's free of HIV or AIDS. I know that's huge in terms of end AIDS campaigns, but what we are interested in is a world where race-related and HIV-related health disparities among Black gay men are vigorously pursued to no end. And I'm going to turn it over to Xavier Robinson, who's going to delve in a little bit about health reform and Black MSM patient communities. Abe?
Perfect. Thank you so much, Amora, and hello, everyone. As Amora mentioned, my portion of this presentation is twofold. First, I'm going to provide a little bit of context with respect to health reform and health systems integration and the broader movement to reform our healthcare system in the United States and how that pertains to Black MSM. And then I'm going to sort of set the table for Tyler's presentation, who's going to go over these concepts in greater detail in terms of how they impact local aid service organizations, community-based organizations, and community health centers. So for us to get started now, I just want to take a look at a quick Affordable Care Act implementation timeline. First, beginning with 2010, we see that President Obama signed the Patient Protection and Affordable Care Act into law on March 23rd of 2010, and we see that that was sort of the impetus for a whole variety of health systems and health reform initiatives that were really targeted at doing three things to the American healthcare system: improving quality, improving patient experience, while reducing per capita cost. In 2011, we see to that end, we see that in 2011, CMS implemented the Medicaid Medical Homes Program, one of the many initiatives targeted at creating a more succinct and coordinated healthcare system for various populations. Then we see at 2012, we see that U.S. Department of Health and Human Services began to promote special initiatives to collect data among populations which are experiencing a high amount of disparities. Then in 2013, CMS indicated the federal match for preventative services in Medicaid, again incentivizing preventative service within Medicaid. On to 2014, we saw the first year of the health insurance marketplaces and the cost-sharing reductions and federal subsidies which were aimed to reduce the cost of private insurance. And of course, this was a game changer for many Black people, many Black MSM. As you all know, the vast majority of Americans receive their health insurance coverage from employer-sponsored coverage. And as socioeconomic disparities and employment disparities are pervasive in the Black community, having access to private health insurance via these federal subsidies is very important. And then in 2015, finally, we see an enhanced federal match for the Child Health Insurance Program. So let's take a look at some specific consumer protections and market reforms implemented by the Affordable Care Act, which are particularly pertinent to the Black MSM community. So let's first begin with ACA Section 1557. Now, this is the section of the Affordable Care Act which specifically deals with non-discrimination. And what it says is that the vast majority of the healthcare system, that's anywhere from health insurance companies to individual providers to any sorts of other organizations receiving any type of federal funds, that they can no longer discriminate on the basis of sex, gender identity, or race, and a whole host of other protections. This is a game changer in terms of the functioning of the American healthcare system. The next thing I want to talk about is Section 2702, which talks about guaranteed issue. Again, this extends those same protections specifically to health insurance and coverage, just really noting that regardless of any of these factors, race and sexual orientation, gender identity being some factors with a whole host of other sort of factors, that you have to issue in health insurance policies regardless of those specific attributes. And then Section 1302 talks about essential health benefits, and again, extends those same protections with regard to the benefit structure of the vast majority of private health insurance plans. And then we see at Section 1311, we see qualified health plans in marketplaces. And again, this is important because those protections are not only included in the qualified health plans in those health insurance marketplaces and exchanges, but it also applies to how those plans are marketed. And so that means that plans can not only discriminate with regard to their benefit structure or who they offer the health insurance plans to, but they can't discriminate with regard to who they market to, meaning that they can't have one particular market strategy which is aimed to exclude rather a specific group of people. So we see that these are the various consumer protections and marketplace reforms which were espoused by the Affordable Care Act, and we're beginning to see tremendous outcomes related to them. I just want to talk about a few of the coverage successes related to Black people. And this data is all from last year, or the third open enrollment period, which concluded on January 30th of 2016. And so we see that last year an estimated 6 in 10 African Americans qualified for Medicaid or the Children's Health Insurance plans or lower costs of monthly premiums through health insurance marketplaces. That's 60% of uninsured Black people in the United States were able to take advantage of some sort of coverage under the Affordable Care Act. For those on the private insurance market, the vast majority were able to find coverage for less than $50 a month, and 7 in 10 found that coverage was less than $100 a month. We also see that 7.8 million African Americans with private insurance now have access to preventative services, which were not previously available prior to the Affordable Care Act in the same way, to the same degree that they are now. We also see that more than 500,000 young adults between the ages of 19 and 26 who would have otherwise been uninsured now have coverage under their parents' plan. And this is, of course, related to the Affordable Care Act provision, which extends health insurance coverage to persons enrolled in college, provided that their health insurance, their parents have health insurance. We also see that 2.3 million African Americans ages 16 to 64 gained health insurance coverage, lowering the uninsured rate among Blacks in the United States by 6.3 percentage points. That's a huge marker. We all know that all states have not expanded Medicaid, but we know that if states were to expand Medicaid, 95% of eligible uninsured African Americans might qualify for Medicaid, CHIP, or a program to help lower the cost of their health insurance coverage marketplace. Now, this last point, this Medicaid expansion gap, is something that I want to focus on in greater detail because there's an overwhelming body of evidence which seems to suggest that states who are failing to expand Medicaid, that the repercussions are disproportionately impacting Blacks and African Americans. So let's take a look at that by first taking a look at the current status of Medicaid expansion decisions. We see that currently 32 states, including the District of Columbia, have elected to expand Medicaid. But the story related to Black folks, particularly Black folks in the South, is very compelling. If we take a look at the 19 states that have not expanded Medicaid, we see that that lack of expansion is disproportionately impacting the Black community. So let's take a look at the 10 states with the highest concentration of Blacks in the United States. If we take a look at those states, we see that 7 of those 10 states have failed to expand Medicaid. And when you think about the repercussions with regard to the access to quality preventive services and medication and quality care and treatment, that's a huge, huge deal. That 7 of the top 10 states that have the highest concentration of Black people have failed to expand Medicaid. So with regard to the Affordable Care Act, I believe it's a story it's a tale of two stories. On the one hand, we've had tremendous coverage opportunities, and on the other hand, Medicaid expansion and the failure of states to extend Medicaid continues to create coverage barriers for the Black community. In addition to coverage, I just want to talk briefly about the national movement to collect sexual orientation and gender identity data. Sort of this journey has been going on for quite a while now, but most recently we see that the Institute of Medicine recommended that all parties collect SOGI data in 2011 and 2012. And we're beginning to see some traction on the federal landscape. So in 2015, we see that CMS and the Office of the National Coordinator noted that they're going to be providing meaningful use incentives to adapt the collection of sexual orientation and gender identity data. And for those of you who don't know, meaningful use is simply the program where the federal government has provided financial incentives for providers, healthcare providers, to adapt information technology and electronic health records to improve their practice. And we see that now, for the first time ever, sexual orientation and gender identity data is going to be one of the criteria by which they will be evaluated for these particular financial incentives. This will take place in Stage 3 of meaningful use, which was going to be approximately around 2018. This is significantly going to increase the number of hospitals, clinics, and community-based providers that are going to be collecting sexual orientation and gender identity data in their EHR systems. Now let's sort of take a look at the broader categorical funding landscape. And I pulled these few graphs. They're from NASDAQ. The graph in your top left corner shows Part B, so that's Ryan White Part B based funding adjusted for inflation. And the graphic in your bottom right corner shows HIV prevention funding, again, adjusted for inflation. And what we see is, while there are ebbs and flows, that generally speaking, the trend seems to be heading down. That when you adjust insurance, when you adjust categorical funding for inflation across Ryan White Part B and HIV prevention funding, we see that the trend is going down, and this is significantly important with regard to sustainability of both community-based organizations and community health centers, because we all know that new infections remain basically flat. So if we take a look, if we adjust for inflation and we see that if categorical funding is going down, we also know that client demand is going up, and this plays hugely with regard to its impact on the sustainability of community-based organizations, ASOs, and federally qualified health centers. So let's put it all together. You know, I talked about health insurance coverage. I talked a little bit about the SOGI data collection and the consumer protections and market reforms, which are all expanding and enhancing access for Black MSM. But what this webinar is really about is sustainability. And we know that regardless of how much coverage is available, regardless of how many great consumer protections and market reforms are available, or which data we are collecting, if Black MSM don't have a good quality medical provider to go to or good quality service provider to go to, then all of it was in vain. And that's why it is our duty in this time of health systems landscape, health systems reform and health reform and the Affordable Care Act implementation, that we begin to think about how are the community-based organizations and the aid service organizations going to remain sustainable, particularly those who are impacting the Black community. And while we recognize that all community-based organizations and aid service organizations might not have a majority Black MSM population, there's also a tremendous opportunity for those who serve a minority population to advance this cause. And so with that, I'm going to turn it over to my colleague and friend, TerMeer, to talk about his journey at Cascade AIDS Project in terms of how they have been navigating these very serious and very real sustainability challenges. Tyler?
Cool. And Tyler, feel free to just press the video icon so we can see you. Awesome.
Great. Well, thank you so much for that wonderful intro and for leading us to this point in the discussion. Today, I have the privilege of talking to you a bit about our journey at Cascade AIDS Project. So do you want to get me to my first slide there, Mara? And actually the next one would be great. So by the end of this session, I am really hoping that U.S. participants will be able to describe the journey towards sustainability that Cascade project has been on over the last 2 years, to talk or be able to discuss the importance of truly investing time and resources into comprehensive planning. It's more than a quick strategic planning process, but figuring out the bridge between transition from a strategic plan to a thoughtful business plan for organizations that may have not traditionally had that time and capacity. And to be able to return to your communities with a better understanding of how the traditional aid service organization or how, as a community-based organization, you may approach issues of sustainability in a shifting landscape. Next slide. So for a roadmap of our discussion today, I'd like to talk to you at first briefly about who we are and what we do as an organization here at Cascade AIDS Project. It will help lay the foundation for our journey towards sustainability as an organization. I'll talk to you about the process, major themes and challenges that we learned from interviewing other aid service organizations thinking about transformation or evolution as a means of sustainability, and then dive into what it has meant to us to remain relevant as an organization with everything shifting around us in the healthcare landscape. I can talk to you about our financial modeling, the opening of our LGBTQ primary care health center early next year, and the financing models that go behind that, as well as talk to you briefly about how health equity and specifically our work with Black MSM fits into this evolution as an organization. As was mentioned a few moments ago, there are multiple cities or organizations that have a smaller population of communities of color, specifically Black MSM. We are certainly that here in Portland, Oregon, but we have been finding our way forward to intentionally do our work with the community that is so disproportionately impacted by this epidemic. Next slide. So Cascade AIDS Project, who are we? We are the oldest and largest HIV-based provider of housing, education, advocacy, and support to Oregon and Southwest Washington. We have an annual budget of about $6.5 million, currently about 65 staff, and we are a unionized workforce. We have a mission that has evolved over time, but currently reads there on the screen, to hope to prevent HIV infection, support and empower people living with HIV, and eliminate HIV-related stigma and health disparities. And our work is based on several values based in social justice, service, community collaboration, compassion, and innovation. Next slide. So for more than 3 decades, we've earned our place as a traditional community-based organization in the community. We as an organization have a strong vision in that we will be a learning organization that is committed to achieving excellence in health equity with an outward vision of achieving a healthier community overall. And, we believe that we are an organization that is here to help put people's lives back together by securing housing and finding essential medical care and dealing with the countless other issues that are going to make a difference between our clients giving up and getting up and being able to move on with their lives, with HIV as just one component of their complex being. Next slide. So quickly, who we are and what we've provided up until the moment we decided we needed to transform. I really believe that CAP's work is largely viewed in 2 large buckets by the community. The first is in our HIV and STI testing programs. Our education, prevention, and outreach work has very largely over time been centered on the gay and bisexual community and the transgender community. We're offering testing throughout multiple communities. One thing that makes us a bit unique as an organization is that we do cross over the state line into Washington State to provide those services as well. But we've evolved as an organization in the last several years as prevention funding has continued to decrease by adding staff that are trained in insurance enrollment, in access to pre-exposure prophylaxis, and have merged our prevention and care teams who are focused on linkage and re-engagement in care. We also have a very large scope of work that spans in housing and supportive services, and that work is very much based on a housing as healthcare model. We fully believe that our patients, our clients, the communities that we serve need to be stable in their life in order to find stability in their health care. And so we work not only to help individuals find opportunities for short or long-term rental assistance, but offer emergency rental assistance and transitional housing. We have navigators that are trained to work with people of a higher acuity who are dealing with mental health and substance abuse issues in addition to their HIV status, peer support, and other client services that are dealing with people who may just need that light touch and assistance to those who are going to need help every step of the way, and a set of education and employment service programs to help people ensure that they're not only stable in their health care, but that they find the stability in employment and in a roof over their head to ultimately impact their overall health outcomes. Next slide. As we look at the next several years for CAP, we created a new strategic plan that was based on 5 strategic imperatives, and we recognized that at the intersection of the Affordable Care Act, payment reform, and the goals of the National HIV/AIDS Strategy, as well as treatment as prevention and the shrinking resources, that we really needed to find a path forward that would help us achieve sustainability, but would also help us maintain our relevance in a shifting landscape and improve our ability to affect health equity in the communities that we serve. So of the 5 imperatives that you see there over the next several years, my presentation today will highlight remaining relevant and our work towards affecting health equity in the communities that we serve. Next slide. Next slide. So in 2013, given all of the changes that we were seeing in the healthcare landscape, we determined that we needed to re-examine what services we were offering and how we offered them. And to that end, in 2013, we began a comprehensive planning process that included many steps from strategic planning to, for the first time, developing a business plan for the organization. We wanted to learn what other organizations around the country were doing as a part of their transformation and in hopes of remaining sustainable in a shifting landscape. But we also wanted to talk to our staff, to our board, and to many of our stakeholders, and to the larger community about the health issues that they were facing, what was happening in the insurance marketplace, and then model out financially what various changes to our current scope of work may mean in terms of sustainability for the organization in present day and moving forward. And then take a more in-depth look at the financing behind what it would mean for CAP to begin providing direct clinical care to the community. Next slide. As we entered this process, we asked ourselves several key questions. Where does CAP have opportunities to link with or add healthcare, pharmacy, or other billable services? What is it that CAP's potential growth will do to our fundraising program as it currently exists, and who or what will the targeted growth funding base be, and what is the value proposition of any change that we may make? How do we test that value proposition, and what core skills or staffing will CAP need to build over time in order to diversify our funding mix and grow our unrestricted funding in order to become a more sustainable organization? Currently, CAP is about 70% funded through government grants and contracts, and the remainder of our budget is made up through fundraising through special events, foundation dollars, and individual major donors not tied to any one specific event housed by our organization. Next slide. We wanted to learn from the field as we began this process. And so we started by interviewing senior managers at 5 AIDS service organizations around the country, and we took a look most closely at Crescent Care out of New Orleans, the LA LGBT Center, the Minnesota AIDS Project, AIDS Foundation of Chicago, and AIDS Resource Center of Wisconsin. And we looked at these various models largely because of the scope of work that they started as and what they evolved into, but also we looked at the current market, the state of Medicaid expansion in their states, and which market might be closest to the market here in the region that we serve. Next slide. The interview topics included everything from the key factors in their success to their lessons learned, and we really wanted to try and figure out what advice they may have for CAP as we took a deep dive into this journey. Next slide. We learned quite a bit from this process, and some of the major themes you'll see on my next slide. They were that we saw that successful ASOs have substantially changed their business models. Out of the ones that we examined, some have become healthcare providers, and one group in particular that we interviewed plays a key policy and advocacy service coordination role within their community. We also learned that some healthcare-focused ASOs have become federally qualified health centers, and some have not. But healthcare-focused ASOs of both types have grown and expanded their impact and improved their bottom line. We also learned that all healthcare-focused ASOs interviewed had an in-house pharmacy, and we wanted to learn more about what that model may mean for us as an organization, and that all ASOs that have not made basic changes in their business model have often struggled financially as the conditions around them changed and as the scope of service that they have traditionally provided was no longer funded in as much of a robust way as it had been in the past through their federal dollars. The challenges that we identified, next slide, are that FQHC status in general posed a great challenge for some organizations, especially if they didn't have that internal infrastructure. We learned that generally primary health care tends to break even financially, and that pharmacy operations have produced surpluses and other services may lose money. And we needed to figure out what that may mean for us as an organization as we took a giant leap and took this big lift forward for a scope of service that had not traditionally been a part of our work. We also learned that ASOs that have not adapted to the changing conditions have faced a loss of identity and key staff and financial resources. In any change that we look at moving forward, we wanted to ensure that we provided a strong sense of integrity for who we have been and that it would be a natural evolution for our organization. So let's take a look at where we've been and how we got there. We wanted to take a closer look at several different models for the path forward for CAP based on what we learned from organizations around the country, taking steps of transformation for potential sustainability in the future, and see if those models would work here in Portland.
Hey, Tyler, am I on the right slide?
Yeah.
Should I move forward? Yes, this slide? Okay.
We looked at 5 different models. First was a baseline. What would it mean for CAP to continue in its current trajectory? We wanted to take a second look at what it would mean to have a stronger focus on the broader LGBTQ community, both through a healthcare focus and one as a joint collaboration of community providers. we wanted to take a look at a strategic alliance with a federally qualified health center, and also what a strategic alliance with a mental health or substance abuse service provider would mean for us as an organization. And rather than just talking through this process internally with our own expertise, we decided that it was important for CAP to consult with an outside partner, and we hired a firm called the Program Interest Management Group to help us develop alternative strategies and to look at the financial models for what that would mean for CAP. So using a financial and operational model of the organization, we built a set of data that would allow us to test different combinations of assumptions and observe the resulting impact on CAP's financial status, our activity levels, and our staffing patterns for overall viability now and in the future. The purpose of this initial analysis was really to fuel our internal discussions and narrow down this set of scenarios to help us further have discussion and make decisions about the road ahead for CAP. And in developing this plan, we analyzed a range of scenarios for the organization's transition. We wanted to make sure that whatever we did would allow the organization to remain financially strong and recognize that perhaps remaining the status quo may bring long-term sustainability for the organization, but would also pose risk for the organization. The other scenarios that we took a look at here on this list all posed other risks for the organization, but we believed that the path forward for the organization that posed the least amount of risk but the highest return would be taking a closer look at an LGBTQ health focus that would not be limited only to HIV/AIDS. Next slide. So as we looked at the path forward, we used a very specific lens for examining these alternative organizational strategies. We had a strong commitment to finding a path forward for the organization that would address a gap or a need in the community, something that would create a new stream of earned income for the organization, but above all, that any transformation that we make must provide a sense of integrity to the mission by which we were built and serve as that natural evolution for the organization. Next slide. So in the next major step of our organizational development, we have decided to build on our core competencies, which have been based in advocacy, education, prevention, housing, and supportive services, and continue to address the needs of people who are affected by HIV by expanding our mission to promote the broader health and wellness of the LGBTQ community. CAP purchased a building earlier this spring, and it will be the site of a new LGBTQ-focused primary care health center. We were able to purchase the building by leveraging funding from our financial reserve and by financing the rest of the building, showing the community a strong investment in the work moving forward, but also as a tool to try and get other investors, foundations, donors on board with the project. Next slide. There are several key reasons why we would open this model. You know, when we were looking at the various models around the country, there are many community-based organizations, specifically AIDS service organizations, that have decided to open clinical care focused on the HIV community. We looked at the market here in Portland and felt that we had a very robust system of HIV services, and that opening a HIV-specific clinic under CAP's name would be very largely a duplication of service. We have a large federally qualified health center at Multnomah County that is currently serving the HIV community, and a strong set of health systems that are providing both infectious disease and primary care to that community. But what we did see from our donors, from the clients that we serve, and through a survey that we did with the broader LGBT community is that there were many folks in our community that felt like there were unique healthcare needs of LGBTQ people, that those needs were being met currently by a primary care provider, but that their overall healthcare experience may not feel safe, or that it may not be a non-judgmental experience. We wanted to provide a culturally affirming clinic where individuals can come for their health care from the moment they walk in, through their provider visit, and out the opposite side through their billing experience, and feel that they have had a healthcare experience that they greatly need and deserve in a very safe and affirming way. Next slide. So as we looked at who this clinic may serve, it was obviously a large shift from the current scope of services that we currently provide and from the current set of patients that we currently see through our supportive services, our housing programs, and our prevention and education services. As you can see on the slide in front of you, the target market for the health center in our business plan will serve the full spectrum of Portland's LGBTQ community. We hope to serve all demographic segments of the LGBTQ community and recognize that all members of our community who would want to attend the clinic, regardless of how they identify in gender or gender identity or sexual orientation, would be welcome to come if they feel that this is a safe and affirming place for them to receive their care. We also recognize that we needed to figure out what a specific payer mix would make the model both sustainable, but would also be filling a true gap within the community. As we looked at that model, at least in the first several years, we came up with the payer mix that you see in front of you. We know that many of our current clients will maintain their HIV care through the local federally qualified health center, but that some individuals would potentially transfer their care, or that we would reach those individuals living with HIV out of care, and that we would have a brand new set of clients from the broader LGBTQ community who would want to come to our clinic. We assume in our business plan that about 50% will be coming from employer-sponsored health plans, 35% from the Oregon Health Plan, OHP, or Medicaid, and then about 15% would be Medicare clients. Patients that identify within traditionally underserved communities here in Portland who identify as Latino, African American, Native American, and Asian will comprise about at least a third of our base, and that patient gender and identity will largely be tracking along the makeup of the LGBT community as a whole. We had a very large discussion as an organization and among our board of directors about whether this payer mix would really be serving those who most need access to our care, those who have traditionally been marginalized, those who don't feel safe in their current care, or the communities of color within Portland who traditionally have not had a safe and affirming place to receive their care. Where we landed was that we needed to do everything in our power to ensure that they do have smooth access to care, but we also need to make sure that we find a payer mix that will both serve those communities and keep our doors open until we have reached sustainability. And that's how we landed on this model here in front of you. Under the new strategy and business model, we hope that this will allow us to diverse the revenue stream that comes into the organization outside of our traditional federal grants and event-based fundraising. But we also know that in addition to the third-party payments that we'll receive through brand new infrastructure that we will have to invest in and build within our organization, that we will also have the 340B pharmacy eligibility, and the revenue under this program will be a key source for our general operating funds by design within our business plan. And those surpluses generated will help the organization remain sustainable and grow into the future. Next slide. The key drivers behind our revenue are volume and diversity of our health center patients, the payer mix of our patients, as I described earlier, the volume of HIV support service clients, the number and type of pharmacy prescriptions, what we also will see and continue to build in terms of our major and individual donor participation, and the diversity of public and private grant support that we can find moving forward. Over the period of our fiscal years 2017 through 2020, the organization's revenue base will obviously greatly transition as a result of this change as an organization. We really felt with the uncertainty and federal funding that we needed to project a conservative assumption that those resources would gradually decline, that our fundraising would remain stable, and that we would partially replace that decline by the reimbursements of medical services and pharmacy services over time, and that the pharmacy revenues would continue to help fund the organization moving forward, which has been used in models across the country and other AIDS service organizations over the last decade. Next slide. As we look at the financial projections for the clinic, we really wanted to see what the impact would be on our current budget, our current sense of operations, and how we would move forward as an organization under this new model. So what you see in front of you here is taken directly from our business plan, and understanding that the pharmacy is certainly a key component of our business model and the success of our sustainability moving forward. We obviously have used very conservative estimates for prescription volume and feel like we will do much better based on the need and the demand that we've already been seeing from the community response after the announcement of this clinic. The total operating budget is projected to rise from our current $6.8 million to $10.4 million by 2020. And over the period, the expenses of our HIV support and prevention and education services will continue to decrease gradually, along with the funding and the volume of services that we're able to provide to the community. But we hope that that will level out after 2020, and that the revenues that we receive from the pharmacy model will continue to allow us to grow as an organization. The payroll will remain our major expense moving forward, and by 2020, the organization's operating cash reserve, which was depleted during the purchase of the building, will begin to replenish itself, and that we will return to our normal 3-month operating cash in reserve by 2020. Next slide. In order to get there, we knew that we needed to think outside of our normal streams of funding. We couldn't rely solely on our normal event-based fundraisers to get the clinic doors up and running, open and up and running. And so we know that over the next several years that we need to raise an additional $1.5 million, which includes about $1 million in operating capital until the organization as a clinic becomes self-sustaining, and that we needed an additional $500,000 in capital project funding to help renovate the building that we purchased. We've looked at several different models of service. We've engaged both our local foundations, our major donors, as well as the local city, county, and state governments to find out what their investment in this project may look like moving forward, and in hopes that they'll come in the foundations of a new and exciting project within the community as CAP begins to evolve. Next slide. So what are the risks? We really knew that headed into this plan that there was going to be risk in any step forward that we took. As I mentioned earlier, remaining status quo or not having any evolution with the trends that we're seeing in our federal funds was not an option for CAP if we wanted to keep the doors open. And many of the other models created opportunities to fill a gap in the community, but not a new sense of earned income that would allow us to become a sustainable organization moving forward. And so we wanted to build a conservative plan that would include the potential to fall short on the health center and pharmacy service revenues. We knew that to mitigate those risks that we would apply this conservative analysis over the first several years, that we would do our best to secure the funding from outside sources, which we're tracking pretty well on to date. And in the event that something went wrong or that we weren't hitting those projected costs, that we would have a range of options to mitigate the loss of operational funds, and that we would have the ability to refocus our clinic on a new initiative to help cut costs or identify additional alternative revenue sources to keep the organization sustainable moving forward. While this step forward posed a possible risk for the organization, and it depends on who you are about how big of a risk you think this might be, the plan that we presented, we believe, frames a very bold yet carefully crafted step forward for us as an organization in taking steps in a new direction that have a very clear value proposition for the organization, that fills a gap in our community, and allows us to implement a new initiative that has backup plans in place if the service model is not achievable within the first few years. Next slide. One of the things that was very important to us as we built this model was to think about how we would continue to serve those communities most marginalized, those communities that have traditionally been underserved or left behind in our region. I think it's important to acknowledge that CAP has had a long and varied history with communities of color and with the transgender community. A lot of feedback that I received when I first started at CAP in mid-2014 was that communities of color over time felt like the organization wasn't investing enough in their health care, wasn't partnering with other organizations that have traditionally had a mission focused on Black communities, specifically Black gay communities. And they wanted to see CAP very intentionally find a path forward that would allow the organization to find sustainability, but that would also continue to address their healthcare needs. As we began to do this work, as we began to build our business plan, we also set out on a journey to define health equity within our work as an organization. As I mentioned at the beginning of my presentation, as an organization, we have committed ourselves within our strategic plan to improving our ability to affect health equity within the community. And this project, the new initiative of a sustainable option for our future, was no different. We as an organization know that we need to acknowledge the central role that health equity plays in our goals to eliminate new HIV infections and in supporting people living with HIV. Next slide. As we started down this road, we wanted to not just have a brief conversation about what health equity means and what our role might be within the work, but we wanted to very thoughtfully create a plan for the organization that would live and breathe right alongside our strategic plan and business plan as an organization. We brought together a group of constituents, our community partners, several of the community members that we serve, as well as our staff and board, and we defined health equity from our lens as the equal opportunity for everyone to be mentally, physically, and emotionally healthy. We also acknowledge that achieving health equity requires acknowledging that health disparities exist and are the result of avoidable inequalities and historical and contemporary injustices. It also requires ongoing collaboration that looks for solutions both in and outside of the healthcare system. In order to do this work moving forward, we knew that we needed to not only define what health equity meant to us, to come up with our health equity imperatives as an organization that would allow us to define our role, but that we also needed to put our money where our mouth is. In order to truly serve this community equally and equitably, we needed to understand what our current services were doing, how they were perceived by the community. And in order to do that, we began doing an annual equity audit of our organization. We also developed an equity lens that we view all of our policies and procedures through, all of our practices as an organization, and all of our marketing and communications. No policy or announcement comes out now at CAP without first being viewed through this specific equity lens. But we also knew that as an organization that is based in a very Caucasian community and state, that we needed to invest in serving the transgender community and invest in serving communities of color and other traditionally underserved populations throughout our region. We couldn't just rely on the fact that state and local dollars were no longer being isolated to serve these communities in meaningful ways, or cross our fingers and hope that one day we would have a federal grant that would help us do this work in the community. So in order to best serve these communities, we went to our board of directors and asked that they consider setting aside 1% of our annual operating budget to serve these communities. So this year, and for the last 2 years, we've set aside about $65,000 to serve traditionally underserved communities in our region. And we've had some really amazing projects. We started a new testing initiative with Black men who have sex with men in the community. We've partnered with local communities of faith and our several Black churches in the region to offer HIV testing and education within their communities. We've partnered with a local sex workers coalition to reach the community through a new health magazine that is written by and for the sex worker community, providing them also with free hygiene kits and free home HIV test kits to ensure that they know their status and can do so in a safe and affirming way. Next slide. Our role in health equity really is to provide low-barrier, culturally affirming services to increase access to care, build coalitions across sectors, empower communities, and advocate for systemic change. And for the purposes of our health equity work, we've defined community by our current mission, which are people living with or affected by HIV, or those impacted by HIV-related stigma and other health disparities. So the slide you see before you now is just a glimpse at the health equity plan that we produced that in partnership with our community and that we are committed to over the next several years. Next slide. The committee set 5 strategic imperatives for the organization to frame our work, and those are listed there in front of you, but I know it's a bit of a small font. So essentially, we are hoping that we will foster an organizational culture that centralizes health equity in our daily work, that it's not just a plan that sits on the shelf and collects dust, but one that we can invest in, one that is meaningful, and one that we check in on a regular basis. That we align all of our programs to reflect the diverse needs of the communities that we serve, whether funding is there or not. That's why we created the grant program for our staff to apply to do work in those communities where we don't always have the substantial funding to do so, and to begin to collect data so that we might have stronger grant applications in the future. We want to also ensure organizational accountability through measurable outcomes. And so each of our programs, both administrative and service-based, have new quality measures that are measured throughout each fiscal year. And each department, whether administrative or programmatic, is required to have an equity-based measurable outcome. We also advocate for policies that eliminate social and economic barriers to health and hope that we will cultivate and expand community-driven and innovative partnerships. We have really taken a great stride towards this work. We want to do all of this work with great intention and make sure that the community knows why we're taking these steps towards sustainability. We recognize that it's a shift for us as an organization, but we believe that it is a very meaningful and strong step for us as an organization. And in building the relationships of trust with the Black community, in particular here in Portland, we knew that we needed to make some very specific steps as an organization in partnership with community partners and the Black community to begin to build that trusting relationship once again. So in order to do that, we hired a local consultant that also is a well-respected member of the Black community here in our region, who is helping us look at our internal policies, at our hiring practices, and at the programs and services that we provide in the community and will provide in our new health center to ensure that they remain accessible and that we are thoughtfully designing any new services in our new health center that will be available and wanted by the community. And if not, that we're creating systems to serve and meet the community where they're at. We've also invested in our data equity work locally here to ensure that we're collecting healthcare data based on race, based on gender identity, and on sexual orientation. And we have repositioned several vacant staff positions to be more targeted towards our work with the Black community. We had an opening for our local peer support specialist, which we tailored towards the Black community, as well as a prevention specialist position that is doing outreach specifically with Black communities, both within the Black MSM community as well as the broader Black community. And through our Minority AIDS Initiative funding, have created culturally specific service navigation through the Black communities here in Portland, and have structured all of this really with hopes that we will be able to build a strong Black services team here at CAP that will help us evolve our work with Black MSM, as well as the broader community at risk for HIV infection. Next slide. So I want to thank everyone for their time today. I know it's quite a bit sometimes to sit and listen to a 45-minute presentation that is very specific to one community and one organization. But I thought I would also share just briefly that what we've really learned throughout this process is that there isn't a one-size-fits-all. Every community is so dramatically different in terms of the funding that they receive, in terms of what the community wants, and in terms of what their community will actually come to. And we have learned quite a bit about who we are, how the community perceives us as an organization, and what we truly are going to have to do to remain sustainable. Any option that you look at moving forward will have risks associated with it, but in order to remain sustainable, in order to take steps towards the future that will provide integrity for who you are as an organization, you're going to have to take some of that risk on as an organization and ensure that you're involving community and a strong investment from your board in those processes. So I will open it up for questions and just thank you all for your time.
Tyler, that was great. Thank you so much. Again, everyone, there is an opportunity to write your questions within the Q&A chat box below. We've actually got a few coming in here. Tyler, one question for you. A participant says that this clinic and this work seems very LGBTQ specific and not necessarily HIV specific. And they wanted to hear you talk about your rationale behind that.
Yeah. We had a very long conversation about whether we would be opening an HIV clinic, and I think I breezed past it earlier in my presentation, but we talked with our local community partners who are already providing HIV clinical care, and we didn't feel like it was a gap in the community. We really felt like we would be duplicating a set of clinical services that we would be essentially asking those who are living with HIV to consider uprooting from one clinic to a new clinic, and and we didn't feel like that was the best for their smooth continuum of care. We really felt like, even with opening an LGBTQ clinic, that there may be some HIV-positive clients that would want to transfer their care, but we've largely committed to our community and to our community partners that if we have a client, especially those who have found stability in their care, that we'll recommend that they stay where they're at, if happy, if they have an affirming environment, and if they're stable in their care. Of course, we want to take anyone who will walk through our doors, but we don't want to bring any more instability into some of our clients' lives who are already facing so many other obstacles.
Yeah, so it sounds like it was about offering viable options, but also supporting folks choosing what works for them and staying where it works.
Exactly.
You brought up some community partners, and speaking of that, we have a participant who asked, did you experience any pushback from either community partners or community members, specifically those serving Black or African American patient communities, and how did you handle that?
Yeah, we were very thoughtful about trying to bring together as many community partners as possible. So when we first started taking a deeper dive in looking at providing this specific clinic, we reached out to our traditional partners serving the HIV and LGBTQ communities, but also our community partners who may not be doing that work specifically, but are serving the Black community and the Latino community and other communities throughout our region. We asked that they be a part of our outreach. We asked that they review the community survey that we were putting out into the community about healthcare needs, about people's current coverage, and about what they wanted services to look like moving forward. And then they, many of them agreed for us to use their distribution list so that the community would know that it was a project that they were supportive of, that they had buy-in to, and that they were hoping to be involved with in the future. And so, I am sure any new project has communities or individuals who are not always going to like the direction of the organization. We've had several conversations specifically about how the HIV community may feel about a shift towards an LGBTQ identity and what that means for the traditional services that we offer to the heterosexual community or to the Black community that doesn't identify as members of the LGBTQ community. And what we've tried to be very clear about in our approach to this conversation and will in our marketing efforts as well moving forward is that Cascade's project, as we've known it as an organization, will remain intact, that we will continue to provide a set of supportive services to those living with and affected by HIV, regardless of where they fit into the community. If those are needs that they have, we will continue to support them in a culturally affirming way. But that we are, as a means of sustainability, we are launching this new initiative as an organization, and that the clinic, while it is focused on the LGBTQ community, will be a safe and affirming place for anyone to receive their care, and that we hope that members of the Black community will want to receive their care at our clinic as well. And I think we've very thoughtfully tried to put together a business plan and a marketing strategy that will meet people where they're at and that will be a welcoming and affirming space to anyone who wants to receive their care here in Portland.
Thank you, Tyler. Xavier, a couple of questions for you, and Xavier is right here with me, so I'm going to move the camera your way. A couple of questions around the ACA and what that means for Black patient communities, particularly Black MSM communities. One participant asked, under the ACA, are there opportunities to leverage case management as an opportunity to share health literacy information, particularly given that many patients will be new to accessing insurance?
Yeah, absolutely. That's a great question. Thank you so much for it. So the first thing that comes to mind is that, and Tyler touched upon this in his presentation a little bit, is that there's this entire national focus around really providing reimbursement for non-licensed, non-clinical staff. And so what I mean by that is we're talking about community health workers, we're talking about peer support folks, we're talking about promotoras in the Latino and Hispanic community, and it's really surrounding, like, what are the ways that, these are particular classes of professionals that have not been really recognized by our health insurance infrastructure and have not been reimbursable. But we know that community health workers and peer navigators are essential to providing great outcomes for Black MSM and other communities. And so specifically, CMS has provided renewed flexibility where Medicaid offices can request a special waiver to seek reimbursement of those services. The other place that we've been seeing this is through the movement for value-based purchasing. So along with the Affordable Care Act and all the things that we've been talking about today, there's a national movement to really incentivize outcomes rather than inputs. And this is another opportunity where organizations like accountable care organizations and other types of financing mechanisms have really been providing an opportunity to provide reimbursement for case managers. I think you raise a very valuable point, though, Maura, and that's really focusing on the fact that this new system is big. It's complicated on an organizational level, as Tyler has pointed out, but it's also extremely complicated on an individual level as well. And there are a whole bunch of resources which are available to assist clients with navigating that. If we're looking at HIV-specific resources, I would encourage folks to check out hivhealthreform.com, or you can check out NAFSAT.org to take a look at a few resources with regard to how individuals can navigate the new healthcare landscape.
Awesome. Thank you, Dave. Very thorough. Another quick question for you, Dave. And this is sort of general. A participant wants to know, what is the outlook of Medicaid expansion in the South? You talked a little bit about that, and given the overlay of where most Black folks live in terms of state-by-state population and the states that have not expanded Medicaid, there is a clear overlap, and they just want to know if you have thoughts on forecasting if that will change moving forward.
Sure. Well, I think it's impossible to sort of say which state is going to expand Medicaid versus which is not, but I can provide a little bit of historical context, and that's, we saw the same thing with regard to CHIP, the Child Health Insurance Program, where states were given the option on whether or not they wanted to expand Medicaid coverage to young folks, to people under the age of 18 and below. And we saw initially a whole variety of states were resistant. Many of those states are the same states that are resistant to Medicaid expansion today, and that we see that over time, every single state in the union did expand for a couple of different reasons. One, it's impossible to argue with kids, right, in providing health care for children. But two, it's a very good financial deal. It's a very financially responsible way to extend coverage to people in your environment. And I think that we're beginning to see harbingers of that movement toward national expansion everywhere. I think one of the most recent states to expand was Louisiana. And, like, who would have thought a year ago? We also have been seeing some other states that that conventional wisdom would probably not predict that they would expand. Arizona is an example of that, and other states. So, it's impossible to say for sure, but I look forward to a day when every state has recognized the value that Medicaid plays, not only for the Black MSM community, but for all folks who are disenfranchised from the traditional healthcare system.
Thank you. So I realized and recognized that we are running short on time. We went a little bit over, but that's because the discussion was so great. I want to, again, thank all of the attendees for participating. Within the next day, we'll be sending out the slide deck as well as our short survey. Tyler, I want to thank you so much for your time with us out there in Portland. And we have a whole new host of webinars coming up in June. So please check us out, folks, and thanks so much again.